Rafe walked through the doors of the emergency room, clutching his right arm. It was wrapped in a dark t-shirt with blood seeping through the cloth. Sweating and in distress, Rafe finds the registration desk, gives the hospital consent to treat him, provides his cousin's address as his own, and tells the clerk, when she asks, that he doesn't have any health insurance. A medical assistant, or MA, escorts Rafe to a chair to check his vital signs, speaking with him in Spanish. ¿Cómo se siente? ¿Qué pasó? How are you feeling? What happened? Rafe responds quietly. I had an accident. I was using a chainsaw to cut a tree for my neighbor, and I lost control of the tool. The nurse arrives to assess Rafe's wound and his medical history. Have you ever been sick before? No, he responds. Have you ever had an operation before? No. Have you been to a hospital before? No. Have you had a tetanus shot? No sé, I don't know. Next, the doctor walks in, and through the MA, explains to Rafe that she's going to numb his arm with an anesthetic and put stitches in his wound so the bleeding will stop. Rafe tolerates the procedure well. He's discharged with a paper bag containing some gauze, a roll of tape, and a tube of triple antibiotic ointment. He stops by the cashier and hands over the $400 he brought with him. He came to the ER prepared. He's told he'll be billed for the rest. Rafe's visit to the ER was rather unremarkable. He got the care he needed. Right? Unfortunately, no. Rafe received great treatment for his injury, but he didn't get all the care he needed. Nobody picked up on what was really happening with him. Rafe didn't tell them that his whole body was in pain, that he'd only eaten beef jerky for a month. His stomach burned and he had severe constipation, and he could barely sleep at night. Rafe didn't tell them that he doesn't have access to a phone, that he's lost contact with his wife and mother back home in Central America, and that he's worried sick about his children. No one knew that Rafe came to the US for a construction job, only to find that he had to work 19 hours a day and would not get paid until he cleared an $8,000 debt that he didn't even know he owed. No one knew that Rafe was trafficked, subject to forced labor in the heartland of the United States. The US defines human trafficking as the use of force, fraud, or coercion to exploit the work and bodies of others. And it's happening all around us. The signs of human trafficking can be invisible, making it very hard to identify. The US State Department estimates that in this country, we've only managed to identify 1% of the people trafficked here. Only 1%. Because human trafficking is a hidden crime by nature. And we are not the best detectives. In medicine, we are generally not well trained to address issues of physical, sexual, or psychological abuse among our patients. Many of us don't ask our patients about exposure to violence or coercion because we don't know how to, or we don't know where to refer them if someone admits to us they need help. Also, frankly, sometimes we don't ask simply because we don't have time. We can do a lot in a 15-minute medical visit, but usually in that amount of time, we can't identify a patient who's at risk for human trafficking and appropriately respond to them. If we truly wish to address human trafficking and other forms of violence among our patients, we'll need to transform medical settings into places that optimize patient comfort and optimize our ability to establish rapport and trust with people who are suffering in isolation. Sadly, the creation of such systems of trauma-informed care is in direct contrast with the trajectory of American medicine, with increasing corporatization, the diversion of healthcare dollars into private profits, and a focus on the efficiency of care delivery rather than the art of medicine. So, Rafe comes to the hospital. The doctors, nurses, and staff don't know that workers in the US can be subject to human trafficking. They don't know how to look for the signs. They don't have time to take a thorough social history or an occupational history. They don't realize that there are legal remedies available to Rafe, and that their encounter with him might be his only window to ever connect with such support. And Rafe, he can't tell the clerk, the MA, the nurse, or the doctor about his situation. He fears no one will believe him. He fears he will be deported before he has the chance to earn any money to send to his family. He's deeply ashamed. He blames himself for being tricked. And deception is a key part of human trafficking. It's one of the things that makes it such a hidden crime, because traffickers use not just overt violence to control their victims, but many people are enslaved with tactics of psychological coercion, brainwashing, manipulation. The perpetrators will also target people who are vulnerable because of poverty, migration, homelessness, addiction, disability, mental illness, stigma, and when it comes to children and teenagers, involvement in our child welfare and juvenile justice systems. Consider Tanisha. She was 16 when I met her. She lived at home with her mother and little brother, but had spent time in foster care when her mom was in jail on drug-related charges. When Tanisha was 14, she met a 20-year-old guy at a fast food restaurant near her middle school. He told her she was beautiful, and no one had ever told her that before. She loved riding in his car with him and feeling free, like a grown-up. One Friday night, after taking Tanisha out to get her nails done, her boyfriend told her he was short on cash. He needed her to help him out. She wanted to help him out after all he had done for her. So they went back to his apartment, and the boyfriend put Tanisha in a room with two of his friends who raped her and then gave him $200. With that act, Tanisha's boyfriend became her pimp, and she became entangled with him in what's known as the life. She also became a victim of human trafficking. Federal law describes inducing a minor to perform a commercial sex act as human trafficking. It's also considered child abuse in many states. When Tanisha was 15, she showed up pregnant at labor and delivery. The nurses there viewed her as a tough kid. They observed her bad attitude, her tattoos, and they dismissed her as a gang member. They weren't aware that pimps often will brand their victims with tattoos in order to mark them as property. They weren't aware that Tanisha was a victim. And what made it more complicated was that Tanisha didn't know she was a victim either. We are missing rare but critical opportunities to empower patients like Tanisha and Rafe with the support and tools they need to escape their situations. So what can we do? First, we can appreciate that people who are trafficked in the US defy stereotype. Yes, they're female, but they're also male and transgender. They're of all ages. They represent every racial and ethnic group and religious background. They come from all over the world. The survivors in my specialty clinic were trafficked from 6 different continents. But they also are born and raised in our own cities, suburbs, and towns. We can learn to engage our patients in ways that allow them to open up to us. We don't want to re-traumatize them or stigmatize them. We want to protect their safety the best we can, but also respect their autonomy. Third, we can familiarize ourselves with the resources in our communities that support trafficked people on their journey to healthier lives. It's sobering to realize that in medicine and public health, most of the time, we will not see the outcome of our efforts to assist patients who we suspect or even know are being trafficked, abused, or exploited. Rather, we're opening doors for them. We're planting seeds of hope that may very well blossom in the future. It may not be us that patients open up to, but with our gestures of kindness, we show them that we care. And that may be the first time somebody has showed them that they care. Eventually, our patients may trust someone to provide them assistance. My hope stems from my experience. For the last 12 years, I've had the great privilege of caring for, advocating for, learning from, and working alongside survivors of human trafficking. When people hear about the work I do, sometimes they're shocked. Sometimes they ask me how I can do work that's so depressing. But this work from the beginning has been extraordinarily rewarding. Yes, survivor stories break my heart. Yes, I agonize over an inequitable healthcare system that doesn't always allow us to provide trafficked patients or other patients all the care they need. But I've borne witness to amazing recoveries. I've seen survivors heal, grow, and thrive after trafficking. I see them generously contributing to our society. The unexpected truth is that survivors of trafficking have taught me not just about trafficking, but about what really matters in life. They've given me strength to face challenges in my own life, modeling the courage I've needed to survive advancing cystic fibrosis, breast cancer, and almost 4 years ago, a double lung transplant. The survivors I've known have taught me about resilience. They survived even though others harmed and threatened to kill them, and things got better. They survived even though sometimes they wished to kill themselves, and things got better. My own death seemed imminent, but I survived, and things got better. If we truly wish to address human trafficking in our communities, we will build resilience. We will channel the horror and outrage that people feel when they hear about this crime into changing our society and our healthcare system to a place where we can help everybody. And we begin by listening to my heroes, by listening to the voices of those who have survived. Thank you.